I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Americans worry a lot about heart attacks. That's why 50 million people take a statin daily. What about brain attacks? This is the People's Pharmacy with Terry and Joe Graydon.
Strokes are an important cause of disability as well as death. We'll hear from a survivor about her extraordinary experience.
We'll also talk with a neurologist who focuses on the overlap between vascular and cognitive neurological diseases. He'll explain the different types of strokes and what puts us at risk.
What advances have been made that can help improve recovery from a stroke?
Coming up on the People's Pharmacy, stopping strokes. How to reduce your risk of a brain attack.
In the People's Pharmacy Health Headlines, many Americans are recovering from their winter holidays, quite literally. According to the CDC, symptoms of fever, sore throat, cough, and congestion are soaring. Rates of flu infection are high, especially in the West, the South, and the Southwest. The primary strains showing up on tests are Influenza A H1N1 and Influenza A H3N2. RSV infections are also rising, and COVID-19 is making many people sick. Test results for COVID are no longer reported, so public health agencies rely on wastewater testing. Those levels are currently going up. The CDC estimates that cases of COVID-19 will continue to increase in the coming weeks.
China is experiencing a wave of upper respiratory tract infections due to human metapneumovirus, or HMPV. This virus was only identified by Dutch virologists in 2001, although it may have been circulating for decades before that. HMPV causes symptoms such as cough, shortness of breath, sore throat, fever, and nasal congestion. Sounds a lot like flu, COVID, or even the common cold. The trouble is the cough with HMPV can last a long time and settle in the lower lungs. It's hard to diagnose because there are no rapid home tests. There are no vaccines against this viral infection, and no antiviral medications have been approved to treat it. As with RSV, the young and the old are especially vulnerable. Chinese authorities are downplaying the seriousness of the infection, but they are encouraging people to take precautions such as wearing masks and washing hands. Cases of HMPV in the U.S. surged in the spring of 2023 and are starting to reappear now.
There's another viral infection causing misery this winter. Instead of attacking the upper respiratory tract, however, this pathogen affects the digestive tract. Norovirus is extremely contagious and cases are rising rapidly. It's often referred to as the cruise ship virus, but that's misleading. Norovirus is responsible for symptoms such as vomiting and diarrhea, not only on cruise ships, but throughout the country. Some experts believe that a new strain may be responsible for the dramatic increase in cases over the last several weeks. Vigorous hand washing with soap and water may help a bit, but norovirus can also spread on air currents in places like public restrooms. The virus is hard to kill and can persist on furniture and clothing for up to a month.
We don't usually think of Alzheimer's disease as infectious. New research suggests, though, that certain common infections may increase the risk of this neurodegenerative condition. A study shows that a protein from the herpes simplex virus that causes cold sores increases with abnormal levels of tau. That's one marker for Alzheimer's disease. In laboratory experiments using brain organoids, cells that produce p-tau help protect neurons from this infection. The researchers suggest that tau phosphorylation may be part of the brain's innate immune response to infection. Neurofibrillary tangles made of phosphorylated tau are typical of Alzheimer's disease.
Another type of herpes virus called cytomegalovirus, or CMV, is also linked to Alzheimer's disease. Researchers have found antibodies to CMV in many donated organs from people with Alzheimer's, especially in the digestive tract. The scientists found evidence of the virus itself in the vagus nerve connecting the gut to the brain. When they exposed brain tissue to CMV, both amyloid and phosphorylated tau proteins increased and neurons died. This suggests a link between CMV and the degeneration typical of Alzheimer's disease.
A new meta-analysis in JAMA Pediatrics raises questions about the safety of water fluoridation. The authors analyzed 74 studies examining the relationship between fluoride and children's IQ. They reported a dose-response relationship between fluoride in water and urine and children's IQ. The higher the dose of fluoride, the greater the deficit. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
Brain attacks, also known as strokes, are a leading cause of disability and death. This year, about 800,000 people in the U.S. will suffer a brain attack. What's that like?
We spoke with Dr. Jill Bolte Taylor in 2021 about her experience recovering from a hemorrhagic stroke. Let's hear from her again before we turn to neurologist Dr. Matthew Schrag about preventing and treating strokes. Dr. Taylor is a neuroanatomist and author of the memoir, My Stroke of Insight, and the book Whole Brain Living.
Dr. Jill Bolte Taylor, welcome back to the People's Pharmacy.
It is so good to be with you again. Thank you.
Thank you. Dr. Taylor, you are the author of an absolutely extraordinary book titled My Stroke of Insight, in which you describe having a massive brain hemorrhage. As a neuroscientist, you were able to understand what happened differently than most people. Can you please take a few moments to tell us about that experience many years ago?
Many years ago. Yes, I was teaching and performing research at Harvard Medical School, and my focus of interest was how does our brain create our perception of reality? And I cared about this because I have a brother who's diagnosed with the brain disorder schizophrenia, and his brain organized information completely differently than mine did. And I thought, at a biological level, what is the difference between the brain of someone who would be defined as neurotypical in comparison to someone's brain, like my brother, who would be diagnosed with schizophrenia? So I was teaching and performing research. I was very happy. And then I woke up one day and I had a major hemorrhage in the left half of my brain. And over the course of 4 hours, the circuitry in my left hemisphere began to go offline circuit by circuit. And this was ability by ability. So by the end of that morning, I could not walk, talk, read, write, or recall any of my life. And yet I was still a conscious person. I just didn't have left hemisphere skill set or personality anymore.
What happened then?
Well,
Because this sounds like this is a big pickle. Here you are.
yes.
You're presumably your brain is telling you were aware that something was going very wrong. And at the same time, you weren't panicked.
Well, I am a neuroanatomist, so I study the anatomy of the brain and I teach the anatomy of the brain. And what that means is that I have a visualization inside of my own mind of how the different cells work together in their complex circuits in order for us to be able to, for example, have sound come in our ear and then ultimately have the perception of sound. The cells that are organized organized in a circuitry level to create sound. Dog is a sound, and then another group of cells in that circuitry places meaning on sound. So this was how I think. And on that morning, I, through the eyes of a scientist, watched these cellular circuits going offline one at a time, of being able to have an assessment of where is the problem. But I had no idea what the problem was, because I'm a neuroanatomist. I'm a PhD. I'm a scientist. I'm not an MD neurologist. So I don't have a lot of experience personally, other than what I read in books and in classes about stroke. But I did know the warning signs of stroke. But in the meantime, I wasn't really exhibiting the typical signs of stroke until my right arm went paralyzed. And then it was like, oh my gosh, I'm having a stroke. I'm having a stroke. And then I thought to myself, wow, this is so cool. How many brain scientists have the opportunity to observe from the inside out this kind of an experience? So I think I was fortunate on the recovery end of having had a severe stroke, because I understood cells and I understood circuitry and I respected the brain's ability to recover. But on the morning of the stroke, when it was happening, I think it might have been a disadvantage, because I was fascinated and curious about it, instead of, I'm not right, I need to call 911 now.
Now, Dr. Taylor, I kind of recall from our first interview that there was at some point during the experience almost a sense of euphoria, which seems bizarre for somebody having a bleeding stroke in the brain.
Exactly. Well, the left hemisphere, the right and left hemispheres are mirror images of one another at a functional cellular level. But those mirror images of one another, they process the same information, but in different ways, so that the right hemisphere exists in the present moment. It's right here, right now. It's perceiving this collage of all of our sensory experiences. And we have the ability to bring our mind into the present moment. We also have this magnificent left hemisphere, and it is designed to take information about the present moment, immediately compare that information to our past experience, asking the question, have I ever had this experience before? And is there a reason for me to have alarm, alert? No, I don't want it, push it away. And then that information, if I feel safe, or even if I feel anxiety, then I have this left thinking tissue, which is my rational brain interacting with the external world. So we have these two very different ways of experiencing ourselves. And on the morning of my hemorrhage, the hemorrhage was in the left hemisphere, and it started as a small break in a blood vessel, and that blood clot just got bigger and bigger and bigger until it completely shut down the circuitry in my left hemisphere. And what that did then was it relieved the inhibiting fibers from that left hemisphere, reaching over into my right hemisphere through that band of some 300 million fibers of the corpus callosum, taking the inhibition off of what was going on in the right hemisphere. And for me, that was an incredible experience of the present moment. And I felt this incredible sense of love and peace and euphoria.
Could you briefly describe the difference between a bleeding or hemorrhagic stroke, the one that you had, and the more common thrombotic stroke that affects so many people every year in this country?
Absolutely. When and it's really important that we understand that blood is brought up into the brain with pretty high pressure system, and blood runs in blood vessels, And blood vessels, then, they don't have direct connection with the neurons, which are the major conducting cells of the nervous system. Instead, there are these little supportive cells called glial cells that sit between the neurons and the blood vessels, because blood, and then the neurons will say to the glial cells, hey, I need more calcium, or I need more potassium, or I need more whatever. And then the glial cells go to the blood vessels and kind of take it out of the blood and then deliver it to the neurons. And I emphasize this because what I'm trying to say is that blood, when it comes in direct contact with neurons, is poisonous. It's toxic. It will actually interrupt the ability of those neurons to communicate with one another, and it may actually kill neurons. And so the two different types of stroke happen if the blood vessel bursts and blood then seeps out into the extracellular matrix, the space between the neurons and the glial cells. Then it can be very devastating to the environment of the brain, making it impossible for the neurons to function or actually kill the neurons. And that is a hemorrhage, when a blood vessel breaks and then the contents of the blood actually comes in contact with the neurons and can hurt the neurons. The more common type of stroke is if a blood clot gets thrown off inside of the body and then it migrates up into the brain. Blood vessels taper, so they become smaller and smaller like a funnel. And that blood clot will travel in a blood vessel until the blood clot is too big to get through that tapering end. And then whatever tissue gets supplied by the blood beyond that spot where the blood clot has now secured itself, that tissue is no longer getting the oxygen that they need in order to survive. And so that's the more typical type of ischemic stroke.
And your stroke was, in fact, a hemorrhagic stroke. Is that correct?
Yes, mine was a special kind of hemorrhagic stroke where I had an artery that was directly connected to a vein. And artery is a high blood pressure system. And so blood comes in through the artery, and then that artery tapers to a really small level where the blood cells have to essentially line up in order in a capillary network. And that's a very, very low pressure system. And then at the other end of that capillary network, normally, is the vein. And the vein essentially absorbs, via osmosis, absorbs the liquid back out and then brings it back ultimately into the heart to get replenished with oxygen. And in my brain, it was an arteriovenous malformation where the artery was directly connected to the vein with no capillary network in between. And as a result, the vein could not take the pressure of the artery and it popped off.
You've been listening to Dr. Jill Bolte Taylor. She's a neuroanatomist whose books include her memoir, My Stroke of Insight, A Brain Scientist's Personal Journey, and her more recent book, Whole Brain Living, The Anatomy of Choice and the Four Characters That Drive Our Life.
After the break, we'll hear from neurologist Dr. Matthew Schrag about how strokes affect the body.
How do doctors diagnose strokes?
You'll learn about the symptoms that should prompt a call to 911.
You'll also hear about a new way to remove blood clots from the brain.
And we'll find out more about bleeding strokes.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, backed by 20 years of scientific research and the maker of the most proven and concentrated flavanol extract in the market today, Coco Pro Cocoa Extract. Cocoa flavanols are among the most studied plant-based bioactives today and are clinically proven to promote cardiovascular and brain health for the long term, supporting a strong heart and better memory.
Get 15% off your order of any CocoVia product by using the discount code PPOD15. Learn more at CocoVia, And remember that discount code is PPOD15.
These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. CocoVia Cardio Health is offered in both convenient capsule and powder formats, with each serving containing 500 milligrams of cocoflavanols to support heart health. More information at cocovia.com.
According to the CDC, someone experiences a stroke every 40 seconds in the United States. Every 3 minutes and 11 seconds, a person dies of stroke.
What causes such brain attacks? And is there anything we can do to reduce our likelihood of having one of these devastating events? A bleeding stroke is less common than a stroke caused by a blood clot in the brain, but the consequences of a hemorrhagic stroke can be especially damaging.
People who have experienced one stroke are at a significantly higher risk for developing another one. We'll discuss how to lower the likelihood of a subsequent brain attack.
We just heard from Dr. Jill Bolte Taylor about her personal experience with a hemorrhagic stroke. We turn now to Dr. Matthew Schrag. He is assistant professor of neurology at Vanderbilt University School of Medicine. His specialty is the overlap between vascular and cognitive neurological diseases.
Welcome back to the People's Pharmacy, Dr. Matthew Schrag.
Oh, I'm delighted to be with you today. Thanks for the invitation.
Thank you for joining us, Dr. Schrag. As a neuroscientist, a neurologist, you have a lot of experience with strokes, and they are a real problem. Most people think of heart attacks, but these days heart attacks are pretty well treated, and we have a number of ways to prevent them. Strokes are still a major, major problem. Can you please describe the two kinds of, we'll call them brain attacks instead of, in the case of the heart attacks, both the clotting stroke and the bleeding stroke? What are they and what's the difference?
This is such an important topic, and I appreciate you letting me discuss it with you. Strokes are a top 10 killer of Americans. We think a lot about heart disease, and we should, but strokes cause a huge amount of not only death among Americans, but also significant long-term disabilities. It's a critically important topic. We can break strokes into two big categories. One is bleeding events in the brain, which we call hemorrhages, and the other is an ischemic stroke, or a stroke caused by a blood clot, which prevents enough blood getting to the brain and causes a portion of the brain to die. We call both of these two things strokes because they often turn up with the same set of symptoms, depending on what part of the brain is involved. You lose the function of an arm or a leg or both, or the ability to talk or the ability to see, or a number of other symptoms very suddenly. And initially, when we meet patients, we don't know if it's a bleeding event or an ischemic event or an event caused by a clot. And so those are the two subtypes that dominate the group of strokes that we're trying to treat.
Dr. Schrag, it strikes me that it's really important to know the difference between a blood clot lodged in an artery in the brain and a bleeding stroke, because they would have completely different ways of proceeding as a clinician. And boy, if you make the wrong choice, you could make things a lot worse.
Absolutely right. The treatments are almost backwards for the two types of strokes. When there's a blood clot, we often want to give patients strong blood thinners just as soon as we can to try to restore blood flow. And obviously, if you were to do that in someone who was actively bleeding, you would cause them a very significant harm. So the treatment for a stroke has to start with rapid brain imaging to tell the two types of stroke apart.
What kinds of images do doctors use for that?
The most important one in those initial minutes after a stroke is a CAT scan. It's a relatively simple scan, but it's very sensitive for detecting blood products. And again, what we're looking for is something that can be done very, very quickly because when patients suffer a stroke, either way, time is the most valuable commodity. As time goes by, we're losing neurons very, very quickly. And the faster we can intervene and remove a blood clot, or identify a hemorrhage and control patient's blood pressure and try to prevent that hemorrhage from expanding. The faster we can do those things, the better people are going to do.
It sounds as though we who may be patients need to be paying close attention to what's happening to us so that if we start to experience some symptoms, we can take action quickly. What sorts of symptoms should we be alert for?
Yeah, this is critically important because time is so critical. Patients recognizing that there might be something going on is the most important first step. And surprisingly, a lot of patients don't develop a severe headache. A lot of people think that head pain is going to be the first sign, and on occasion it is. But for most patients, they don't have much pain. And so sometimes people will just go to bed and see if the symptoms wear off, and that can cost valuable time. And so we tell people not to ignore the symptoms. Strokes usually start suddenly, not always, and they often have asymmetric symptoms. So they affect one side of your face and cause a facial droop or slurring of your speech, maybe a little bit of drooling. It often affects one side of your body more than the other. So you may have weakness of an arm or leg or both. It can affect your vision. And so you may lose vision in one side of your vision or in one eye. Any of these asymmetric sudden symptoms should prompt somebody to call 911 and come to the emergency room just as fast as you can.
Now, one of the challenges that people face as soon as they get to the hospital is what kind of treatment after they've determined what kind of stroke is happening, whether it's a clotting stroke or a bleeding stroke. There are some new treatments that involve actually putting in a device that can remove the clot. Can you tell us a little bit about that?
Absolutely. This changed the game for stroke care. I have to tell you, as a medical student, working on the stroke service was one of the saddest, most devastating experiences of my training because so many patients suffered these strokes and we had so little to offer them. So, for many decades now, we've been able to give people strong blood thinners, and that helps a little bit. But it doesn't consistently open the blood vessel when somebody has a clot. So, in the mid 2010s, there was this huge breakthrough where surgeons and stroke specialists working together discovered that you could thread tiny wires through somebody's arteries and fish that blood clot out and get the vessel open at a much higher percentage of the time. And importantly, this works for the largest strokes. So for the patients who are at the highest risk of disability, if we can get to them soon enough, it's very often a possibility to remove that blood clot with a fairly minimally invasive and fast surgical procedure. And so that dramatically changed the landscape of stroke care. Many more patients were treatable and were able to survive with smaller deficits. Time is still critically important, but it also allowed us to treat a lot of patients later in the process than we thought was previously possible. So things are getting much better.
Well, that sounds very hopeful. But as I understand it, the rate of strokes has been going up. Am I wrong?
Do you know one of the metrics that seems to be going up is the prevalence of stroke, which is a complicated metric because prevalence takes into account not only how many people are having strokes, but also how long they're surviving with them. So it's a mixed bag, right? The prevalence of stroke going up can be because people are having more strokes, but it can also be that they're surviving with them longer. And so that's something that we're paying a lot of attention to. But interestingly, the increased prevalence of stroke should have us focusing on stroke rehabilitation, right? This means that more people are living with strokes for a longer period of time. And that's what we want. We want patients to be surviving their strokes, but it means that we need to focus on developing new and better techniques to help people recover from their strokes and prevent second strokes. And so we're really trying to lean into the science of stroke prevention and stroke rehabilitation. There are huge opportunities there.
Well, let's talk a bit about preventing strokes? Because in the case of heart disease, what we hear over and over again is you've got to control blood pressure and you've got to reduce atherosclerosis, that clogging of the coronary arteries. I'm assuming, but perhaps incorrectly, that similar strategies would be important for preventing those ischemic clotting strokes in the brain.
Absolutely right. A lot of the things that you do to take care of your heart are going to be the same sorts of things you're going to do to take care of your brain. And we, after somebody has had a stroke, are going to put them through a series of tests to try to understand what caused the stroke and to target our prevention efforts to a specific patient and to their risk factors. But if you look at everybody across the board, the single biggest risk factor for stroke is high blood pressure. Nothing else even comes close. We talk a lot about smoking, and man, that's important. We talk a lot about controlling your weight and getting your BMI down and eating the right kinds of diets. All of those things are important. Nothing comes anywhere close to the effects of high blood pressure. And importantly, high blood pressure is the number one cause of hemorrhages and ischemic strokes. And when we look at the entire globe, when we look at Asia, Africa, Europe, the United States, South America, the entire globe, it's the biggest risk factor everywhere. If you splice socioeconomic levels, or if you look at the data based on race, it is the number one risk factor for everybody across the board. And importantly, we have all the tools that we need to control this risk factor. We have cheap, very effective drugs that people do well with, and you can measure and manage your own blood pressure with a $30 gadget from Walgreens or Walmart. And so this is a risk factor that people should be hearing loud and clear that this is fixable.
I'm assuming that part of the reason it's such an important risk factor is because it's so very common. My understanding is almost half of American adults have high blood pressure.
Absolutely right. And it is described as the silent killer because you can't really feel it, right? Most people don't find out that they have a problem until something goes wrong, like a stroke or a heart attack. And it's one of the reasons we want to bring it to people's attention because if you check it and pay close attention to it, it's a very targetable risk factor. It's a very treatable risk factor.
So, Dr. Schrag, it's risky to compare our blood vessels to a, for example, garden hose. But, people who have gardens are familiar with the fact that sometimes a garden hose will spring a leak and then they have to patch it. So I'm wondering, well, okay, how do we prevent one of those bleeding strokes? And I'm assuming now that clotting strokes are far more common than bleeding strokes, but a bleeding stroke and a hemorrhagic stroke can be much more devastating to the brain. Have
That's
I got that right?
absolutely right.
Okay.
That's absolutely right. So, in rough numbers, clotting strokes are about 3 times more common. But when you look at mortality, hemorrhages make up about 50% of the mortality from strokes. So, they're very, very dangerous strokes. And interestingly, when we look at the causes of hemorrhage, there are a number of different diseases that cause bleeding in the brain, high blood pressure being far and away the most common one. But another that I've focused my research on called cerebral amyloid angiopathy causes, as you're describing, the blood vessels to become very brittle and prone to breaking in older adults. And this is a form of hemorrhagic stroke that's linked to Alzheimer's disease and aging. But regardless of what the underlying cause is, the treatment, the preventative strategy is almost exactly the same. We need to get the blood pressure down, even in patients where the primary problem is not that their blood pressure is too high. And you can imagine if you had a brittle garden hose that had been sitting in the sun too long and became very delicate and you didn't want it to pop, one way to do it is to just run the pressure in that garden hose lower. And that turns out to be exactly what we do in patients. When patients have cerebral amyloid angiopathy, this disease where the vessels become brittle, we've found that strict blood pressure control can lower the risk of a second hemorrhage by about 70%. And there's very little in medicine that we do that is not effective.
Well, I am curious about things that may make our blood vessels more vulnerable to bleeding, and one of them might be anticoagulants. We hear periodically that doctors have kind of changed their tune on aspirin because it may slightly increase the risk of a bleeding stroke, but even some of our more powerful anticoagulants may do so. And then I'm wondering about other drugs. For example, fluoroquinolone antibiotics, Levaquin, Cipro, ciprofloxacin. These drugs have caused problems in the aorta, where people have the aorta actually kind of fall apart. They call it dissection. Tell us about how drugs may affect the quality of those arteries in the brain.
Well, I mentioned earlier that most of the things you do to take care of your heart are the same sorts of things you're going to do to take care of your brain. But there are occasions where you have to thread a needle, where you're treating heart problems and you're trying to avoid having problems in the brain at the same time. And often the use of strong blood thinners is one of those areas where we need to have people on blood thinners to protect their heart or protect other organs, but it creates some risk related to bleeding in the brain. And there you have to do a little bit of rough doctoring. What we typically do is carefully measure people's risk factors and try to balance those risks and benefits and make the right decisions. So, in general, there are still definitely times when people should be on aspirin or strong blood thinners where that's the right decision. But we have generally stopped recommending people take an aspirin just because. We used to have people as they get older take an aspirin for pretty not strong indications. And new data has come out showing that that increases the risk of bleeding without giving enough benefit to outweigh that risk. And so there has been a little adjustment in how we treat people who are healthy. But once you've had a stroke or you've had a heart attack or you've had a stent or some other problem with your blood vessels, then it becomes necessary to be on blood thinners longer. The other thing that's coming along that I think is really interesting is when patients have atrial fibrillation, when their heart slips out of rhythm and they have to be on the strongest blood thinners. For patients who can't tolerate that, who have had problems with bleeding, there are new strategies, including putting a device in the heart to prevent the formation of clots in certain areas of the heart. We call this a left atrial appendage closure. And that can be an advantage where somebody can potentially lower the risk of stroke without having to be on those strongest blood thinners for the rest of their lives. And I think these sorts of strategies, these innovations, where we look at the problem and say, let's not pick that you have to either accept the stroke risk or accept the bleeding risk. Let's see if we can innovate new things that might be able to help patients in both areas. These are the strategies that are going to make a difference in the future. And so I think we are seeing lots of progress and there's lots of opportunity to continue making new discoveries.
You're listening to Dr. Matthew Schrag. He is Assistant Professor of Neurology at Vanderbilt University School of Medicine. Dr. Schrag's specialty is the overlap between vascular and cognitive neurological diseases.
I think, Terry, that a lot of people sort of get lackadaisical about blood pressure. But Dr. Schrag's point that it's such a critical factor when it comes to stroke that I think you can't just rely on having your doctor measure your blood pressure once or twice a year. You've got to do it yourself at home, maybe on a regular basis.
Well, one thing we know is that blood pressure changes throughout the day.
Exactly right. And now that we have smartwatches, you can also monitor yourself for atrial fibrillation. Well, it's time to take a short break. After we come back, we're going to learn more about AFib and how to find out if you have a problem where your heart increases the risk for a brain attack.
How could you tell if you might be experiencing atrial fibrillation?
Do the medicines you take increase the risk for AFib? In particular, how do drugs like ibuprofen or naproxen, those popular pain relievers, affect your risk?
Doctors treat AFib with anticoagulants to prevent dangerous clots, but of course that means an increased risk of bleeding. How can you find the sweet spot? You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. CocoVia Memory Plus is formulated with 750 milligrams of cocoflavanols, a level clinically proven to improve 3 different types of memory and support brain function. More information at cocovia.com.
Today, we're talking about stopping strokes. What steps can you take to reduce your risk for having a brain attack? What advances have been made to improve recovery?
We're talking with Dr. Matthew Schrag, assistant professor of neurology at Vanderbilt University School of Medicine. His specialty is the overlap between vascular and cognitive neurological diseases.
Dr. Schrag, we were just talking about atrial fibrillation and the fact that that might be a problem in terms of putting people at risk for a stroke. Can you tell us what is atrial fibrillation and why would a problem with your heart have any impact on your brain?
That's a great question. So, atrial fibrillation is a misfire in your heart. Your heart should have the upper chambers, the atria, fire one moment before the lower chambers, and that creates this forward propulsion of the blood, and it's part of how the pump works. But in some people, and often folks who are getting older, you can have a misfire in that electrical system where the top chamber doesn't fire properly. Instead of having a organized contraction, the top chamber just sort of quivers. But what ends up happening is that top chamber, when it quivers, it doesn't empty properly. And there's a little pocket on the left atrium. It doesn't really do much for an adult. It's formed as part of how the heart develops embryologically. And so it's a leftover little pocket on the heart simply from how you were put together as a baby. And that little pocket can have a little blood pool in it and form a blood clot when the top chamber is not emptying well. And then when your heart goes back to pumping properly, those clots can be launched and they can land anywhere in your body, but we're particularly concerned if one lands in your brain because it can cause a stroke. The typical approach to solving this problem is to put people on strong blood thinners. We used to use a lot of Coumadin, and we still use it some, but we have newer blood thinners in the same family. So we like some of the newer drugs better than Coumadin. But the idea is these blood thinners make it a lot harder for a clot to form in that pocket.
How would a person know if they were experiencing atrial fibrillation?
Do you know, when I was an intern right after medical school, I asked every patient that I saw with atrial fibrillation if they could feel it. And there are some people, maybe 10 or 15% of people, who can feel the moment their heart slips out of rhythm. The vast majority of people feel nothing at all. Occasionally, somebody will feel their heart is racing for no reason, where it's sort of not in the right context for their heart to be racing. And occasionally, somebody might feel that their energy was just off. But in a lot of cases, we just don't know. And so, when somebody has a stroke, one of the things that we do is a long-term period of heart monitoring, just to make sure. And you'd be surprised how often we find atrial fibrillation. Atrial fibrillation is more common as you get older. So, particularly in healthy older adults who've had a stroke and there's no good reason for why, that's often what we find down the road once we've done a period of heart monitoring, is that they slipped into atrial fibrillation.
You know, Dr. Schrag, we have discovered that NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen and naproxen, and the prescription drugs like meloxicam and diclofenac that the rheumatologists love so much, that all of the NSAIDs can slightly increase the risk of atrial fib. And literally tens of millions of people pop an NSAID every day because of their arthritis pain or their, sore back. What should we be telling them about the problem of NSAIDs and atrial fib?
Well, I'm not sure that I have a strong enough read on that data to know if we should be recommending a change in treatment, but it's certainly the sort of thing that we're going to be watching carefully. If we can predict who's at higher risk of atrial fibrillation, we might be able to do more careful screening for those folks. But the single biggest risk factor, the biggest one, is aging. So this is something that becomes much more common as we get older, even if we're very, very healthy. So in most cases, patients with atrial fibrillation aren't doing anything wrong. and haven't missed any particular steps in their care. It's just a feature of an aging electrical system in the heart.
Well, it seems like they're walking a bit of a tightrope because once they have atrial fib and their heart isn't beating on a regular basis and their doctor prescribes an anticoagulant medication, then there's the risk that if the dose is a little too high, it might lead to a bleeding stroke. It's like the porridge and the three bears, not too hot, not too cold, just right.
That's exactly the right analogy. We can certainly cause some harm by putting the wrong people on blood thinners. We had this experience recently as a field. We ran a number of clinical trials saying if a stroke looks like it came from the heart, but we were never able to prove it, should we put people on blood thinners anyway? And not only did that not help, it actually, in some cases, seemed to cause a little bit of harm. So we wait. We wait until we've proven that somebody has atrial fibrillation, that we've caught their heart out of rhythm before we put them on blood thinners. And we have algorithms to try to ballpark what the risk of bleeding is compared to what the risk of a stroke is. And we try to make sure that ratio is right. But there are clearly patients, many patients, who benefit from blood thinners. And sometimes we can overestimate the risks of being on blood thinners. So I've had lots of patients who were taken off their blood thinners for atrial fibrillation because of a risk of falling. And certainly if somebody's risk of falling is high enough, you might consider doing that. But for most patients, even if they're getting a little bit wobbly, you're probably better off getting physical therapy or having them use a cane or a walker rather than taking them off of the blood thinners when they have atrial fibrillation, because the risk of stroke is fairly high and the potential disability from a stroke can be pretty devastating.
Now, when you mention a risk of falling, I also think about our conversation earlier this hour when we were talking about controlling blood pressure, because one of the problems that can happen, it doesn't happen all that often, but it can happen with blood pressure medication, is that a person starts to feel dizzy or lightheaded and they're at risk of falling. How do we thread that needle?
Boy, and that's a really important issue, particularly for older adults. People can get much more sensitive to low blood pressure. Not too long ago, we used to let people's blood pressure drift a little bit higher as they got older. And we just said that it was okay if you were older to let your blood pressure run high. And we're finding that that can actually have negative results, not just from a stroke perspective, but from an overall longevity perspective. People who have normal blood pressure throughout their life tend to live a little longer. So we're trying to be more aggressive about keeping people's blood pressure right. But you do have to be practical about this, because it doesn't help to have a normal blood pressure and pass out and hit your head on the floor. That just doesn't make sense. In my experience, the most important factor here is that you treat an individual patient as an individual. And so when we have these guidelines and those overarching targets, these things should be taken with a grain of salt for an individual patient. And often we can get them to those target numbers gradually and avoid some of these side effects. But you do sometimes have to use some common sense. And so that's why we encourage people to have a close relationship with their doctors and to watch these risk factors together.
Dr. Schrag, I'd like to change gears a bit and talk about cholesterol. Many years ago, we were talking with Dr. Walter Willett, who was at the time chair of nutrition at Harvard School of Public Health. He is one of the great leaders in the field of diet and cholesterol and heart disease, and has done an awful lot of epidemiology. And he said to us something that just shocked us. He said, if LDL cholesterol goes too low, it can increase the risk for bleeding stroke. And Terry and I just looked at each other in astonishment. He said, well, actually, in Japan, they are at greater risk of bleeding stroke than they are here in the United States by quite a significant margin. And we think it had to do with their low LDL cholesterol and their low cholesterol in general. And there was even a campaign many years ago to actually raise people's cholesterol to prevent bleeding stroke. And Terry and I just couldn't believe our ears. So can you tell us a little something about cholesterol and the integrity of blood vessels and this whole business about hemorrhagic stroke?
So that's a complicated conversation because some of the data that we've seen has come on both sides of that question. So there was absolutely a series of studies that came out that raised the possibility that low, especially very low LDL cholesterol, the bad cholesterol, could be linked to an increased risk of hemorrhage. And then there was some other epidemiological data that came out that questioned that assumption. And I think the only answer I can tell you right now is that we're not 100% sure. There was a new class of anti cholesterol drugs that came out recently that was an injectable form, drugs like Repatha or evolocumab, which I can't really pronounce properly.
Right.
Um, but these drugs dropped LDL cholesterol to extremely low levels, levels that would have raised eyebrows for a lot of us. And yet, in those clinical trials, they seem to have very good effects on preventing strokes. And so I think this, for a lot of us, is an open question exactly what the connection between LDL cholesterol and hemorrhage is. The data isn't 100% clear on that topic. At the moment, what I know is that lowering your bad cholesterol makes your risk of having an ischemic stroke lower, and it makes your risk of heart attacks lower. And so generally, we're looking to push the LDL cholesterol low. And is there a floor that we shouldn't go below? It's entirely possible. And so we're trying to be practical about that, but we don't know for 100% sure where those thresholds should be yet.
So, for prevention, we're looking at controlling blood pressure, we're looking at keeping cholesterol under a lid. Now, what I'd like to talk about briefly is after someone has a stroke, how do we get them back to their life? What sorts of improvements are being made or might be made for rehabilitation?
This, I think, is one of the most interesting areas in the entire field. Rehabilitation is an area that has a lot of room for scientific growth. It has some very good science already showing that physical therapy and speech therapy, that these treatments make a difference. And trying to fine tune those approaches to individual patients to accelerate their recovery and maximize their recovery is something that really should be the next phase of treatment. And there may also be some interventions, some treatments that we could apply in the later stages of stroke care. We often think that at the late stages, once the stroke has happened and the neurons are gone, that we're out of options. But that's not necessarily true. Some of the symptoms that cause people problems, symptoms like spasticity, where the muscles contract and cause an arm or a leg to be stiffer than it should be, those things can be treated now, both with pills or with injections like Botox that can relax those muscles and help people to move a little bit better, often causing some improvement in pain management. There's also some experimental things coming. There's been some very interesting early stage clinical trials looking at transplanting stem cells into the stroke bed areas or looking at nerve grafts that may be able to give movement back to a limb that is damaged by a stroke. And so I think none of these things are really ready for prime time, but they're very interesting scientifically and may give us a sense of what the future could look like.
Dr. Schrag, as we come to the close of our interview, I wonder if you could just run down all of the preventive strategies. And I think people are interested in lifestyle first.
Yeah.
What should they be eating? What should they be doing? What should they not be doing? What kinds of blood pressure measurements should they be aiming for? And then what are the symptoms that should get them to an emergency department as fast as possible because it can make such a huge difference in the outcome?
Perfect. This is the most important question of the day. So I love this. When I talk to my students, I tell them the top three things you need to do to prevent stroke is control your blood pressure, control your blood pressure, and control your blood pressure. This is the biggie. And so I would recommend people go and get a blood pressure cuff and check your blood pressure regularly. If it's wildly out of whack, you should be checking it every single day. If it's reasonably close, you should be spot checking it every couple of weeks to make sure that it's not drifting out of range and you miss it. And so I think having patients know that they can be in charge of their own blood pressure is the number one best they're in. And if you're not seeing most of your blood pressure readings at or around 120 over 80, plus or minus 10 maybe, you should talk to your doctor about it and see what can be done about it. So that's the single biggest takeaway from this, is that patients can be responsible for their own blood pressure. And then after that, the next most important things for prevention are, if you're a smoker, stop smoking, get your cholesterol checked. And if it's high, let's get it treated either with your diet or with your medications, or preferably both. And then get active, get physically active, get out and move, and eat the right kinds of things. There are specialty diets, some of which perform better than others. We really like the Mediterranean diet, where people eat lean meats like fish and chicken, and olive oil, healthy fats a little bit more. But the truth is, any of these diets where people are really paying attention to getting healthy are probably okay. I think making sure that you're giving your body the building blocks it needs to take care of your heart and take care of your brain are the right steps to take. And then there are specific steps that specific patients should take. So if you're at risk of atrial fibrillation, you should talk to your doctor about getting screened for that. If you have plaques in your heart, you should probably get your carotids checked. And so there are specific steps that should be taken by patients who have other medical problems, and you can discuss those things with your doctor. If you ever have a sudden onset of symptoms where you have a facial droop, where you suddenly lose the ability to speak, where you suddenly are unable to move an arm or a leg, where you suddenly can't walk, where you suddenly lose the ability to see, either on one side of your vision or in one eye, those things should prompt you to get a stroke evaluation as soon as you can. And you should probably not drive yourself to the hospital for that. I mostly say that for the men that I treat, that this seems to be a guy thing where they try to drive themselves to the hospital, and that can go badly. This is a time to pick up the phone and call 911. And the sooner you get care, the better you're going to do.
Dr. Matthew Schrag, thank you so much for talking with us on the People's Pharmacy today.
It's my pleasure to be with you.
You've been listening to Dr. Matthew Schrag. He's assistant professor of neurology at Vanderbilt University School of Medicine. His specialty is the overlap between vascular and cognitive neurological diseases. We'll be talking with him again soon about his research into Alzheimer's disease.
And I'm really looking forward to that interview. That's going to be great. We spoke earlier with Dr. Jill Bolte Taylor, neuroanatomist and author of My Stroke of Insight and Whole Brain Living. You can access our original interview with Dr. Taylor by visiting our website and searching for show number 1265. The Advantages of Whole Brain Living.
Lynn Siegel produced today's show. Al Wadarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is made possible in part by CocoVia dietary supplements. Cocoflavanol supplements that support cognitive and cardiovascular health, made with a proven concentrated flavanol extract. You'll find more information at cocovia.com.
Today's show is number 1413. You can find it online at peoplespharmacy.com. That's where you can share your comments about today's interview. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider, including YouTube Music. You'll find the podcast on our website on Monday morning.
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you'll also have regular access to information about our weekly podcast, so you can find out ahead of time what topics we'll be covering. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.